started on our. I'd like to thank everyone for joining us today. Just a reminder to let us know that you were present at today's rounds by answering a quick survey at the end of the presentation. And please leave your questions for the end. We will please enter them in the chat. Today's speakers come to us courtesy of the Division of Infectious Diseases, and our Chief of the Division of Infectious Diseases, Dr. Baer, will introduce the speakers. Thanks for joining us. Go ahead, Marcel.
Thank you, Nadia. It's a pleasure to introduce two speakers who are going to be sharing the hour. We have Stephen Tong from Melbourne, Australia, and I believe it just turned 3 a.m. in Melbourne. So thank you, Stephen, for joining us. Stephen trained in infectious diseases and also has a PhD from Darwin University, and then did beyond an MD and PhD postdoctoral training at Duke University and at Cambridge at the Wellcome Trust. He's got a number of important achievements, including discovering species of Staphylococcus, discovering a novel genotype of hepatitis B, and he's also become well known for conduct of clinical trials for the management of bloodstream infections and other infectious diseases. He's the lead of the SNAP trial that you're going to be hearing about. And the other speaker today is from our own division, Todd Lee, who's an associate professor. He's an infectious disease physician, originally from the University of Toronto. And I think he's still a diehard Toronto Maple Leafs fan. But after completing 3 years of residency in Toronto, he came to McGill. He also has a master's in public health from Harvard. And recently he's had an incredibly meteoric research career where his publications are really hard to keep track of. He's doing clinical trials, he's doing systematic reviews, and he's now already recognized not only with an FRQ Junior 2, but he last year, just this year, got the mentorship award from the Canadian Foundation for Infectious Diseases for all the other people he's trained and all the enthusiasm he brings to infectious disease research. So I'd like to thank Stephen and Todd for presenting. I'll turn off my microphone and give the Zoom over to them.
Great, thanks very much, Dr. Baer, and thank you very much for the welcome and opportunity to present at this meeting. So Todd and I will take turns here. By the end of this session, hopefully you'll comprehend the magnitude of the problem of Staph aureus bloodstream infections, be able to explain the difference between random care and randomized care, something of the concepts behind a platform trial. And really, we're hoping to create excitement and engagement for the international launch of the Staphylococcus aureus network adaptive platform trial, which has been a real dream of myself and others, including Todd and my co-PI in Australia, Joshua Davis, for a number of years now. It's very exciting for us to get to the point now of almost being open for recruitment. Thanks, Todd. So one of the things really is that Staph aureus infections are a deadly infection and also very common. This is United States data in a nice graphic, about 120,000 episodes each year, of which approximately 20,000 deaths occur. And next slide. And these are the kind of comparable numbers in Australia and Canada. In Australia, we have an overall population of about 25 million. And of that, there's 5,000 episodes per year of staph bacteremia, of which again, about 20% mortality for each episode. So kind of at a localized setting at my hospital, the Royal Melbourne Hospital, we would have between 80 and 100 episodes per year. So each of those is seen by the ID service, which means we're seeing, 1 to 2, for most weeks, two episodes each week. And so it really does become our bread and butter. And the mortality rate is pretty similar. In one of the trials we conducted, it was 18% at 90 days. And in one of Todd's randomized controlled trials, it was also approximately 18%. And the numbers, probably reflective of the larger population size, are a little bit higher in Canada in terms of absolute numbers for episodes and deaths. We often think of how terrible and severe meningococcal disease is, and also invasive pneumococcal disease. But you can see from this graph, which is data from my jurisdiction or my province, Victoria in Australia, that over these years here, staphylococcal aureus bloodstream infections far outweigh those of Neisseria meningitidis and Streptococcus pneumoniae. And in fact, when we think about even the mortality rates from each of those, Staph aureus bacteremia has about a 20% mortality per episode, whereas those two other invasive infections, it sits around 7%. And when you translate this in Canada to the estimated annual number of deaths, Staph aureus bacteremia causes almost twice the number of deaths of many cancers, is getting up towards what breast cancer deaths are. And when I've looked at the data, the 5-year survival rate for breast cancer nowadays is something like 90%, whereas the 90-day survival, not the 5-year survival, but the 90-day survival for Staph aureus bacteremia is around 80%. Snap. So there is an evolving management of Staph aureus bacteremia. You would hope that we're getting better at this over time, given how common this disease is. And certainly some of these are becoming more standardized and protocolized. So we have good data to support the need for repeat blood cultures to show clearance of the bacteremia, the need for line removal and removal of infected prostheses, echocardiography to determine if there is underlying endocarditis. And interestingly, infectious diseases consult in itself has been consistently found to reduce mortality from this disease. There's other aspects which are more variable, so exactly which diagnostics we might choose to use, whether it's a transesophageal or transthoracic echocardiogram, and then which antibiotic, what dose, whether we should step down to oral antibiotics and the exact duration of therapy. These are all quite variable in our practice. And so this is what we would call random care, which really is a function of which doctor sees you that day, their individual and local and daily practices, and what resources are available at your centre. So, I think to the frustration of our non-ID colleagues, when we do consult on such patients, other units often say, well, Dr. Tong, you prescribed, CLOXACILLIN for this patient, but last week, Dr. Lee prescribed cefazolin for the same, almost exactly the same patient. Why is that variation in practice? And indeed, there is quite a bit of random care that we're providing. And so this is just an example of that. We conducted some surveys of Australian and New Zealand infectious diseases physicians. So this is the 3 pie charts on the bottom of this slide, asking them for an uncomplicated case of methicillin susceptible Staph aureus bloodstream infection, how this patient would be treated. And at the empiric stage, prior to knowing it's MSSA, but knowing that it's Staph aureus, you can see that there's quite a bit of variation in the agents that are chosen. So be it vancomycin or a combination of vancomycin and anti-staphylococcal penicillin, or just an anti-staphylococcal penicillin. Once we got to the directed therapy, knowing it was MSSA, almost everyone in this survey, this was from about 3 years ago now, chose flucloxacillin, which is our equivalent of your cloxacillin. If this was a penicillin susceptible Staph aureus, which Todd will talk about a bit later, about 2/3 of participants chose benzyl penicillin as the treatment of choice. So you can see that across these, there's quite a bit of variation. A similar survey in the United States is represented in that upper pie chart there. And about 1/3 of patients or participants chose NAFCILLIN, 1/3 cefazolin, and 1/3 thought that these were equivalent. And it's such a beautiful pie chart in the distribution to demonstrate real, what we would say, equipoise in terms of the choice of agents to be used for this very specific disease. Snap. And so really we're looking at this idea of, instead of providing random care, to randomize that care.
And so, random care isn't unique to the management of infectious diseases. And in fact, if you look at all of your subspecialties of medicine, you'll see that there are aspects of care where individual variability plays a substantial role in the treatments which are chosen, and where we don't necessarily know whether one treatment is better than the other. And there can be observational level approaches to try and understand how two agents or two strategies or even three strategies might compare. But these observational analyses, often performed retrospectively, sometimes prospectively, are subject to a number of biases. And I think that, you know, this article by Telege et al. In Open Forum Infectious Diseases talks about COVID-19, but really lays it out in such a wonderful template for the application to almost any question in clinical medicine. Observational studies are subject to innumerable biases, like confounding, either residual confounding because you lack the granularity to adjust, or by severity or indication. When I'm treating Staph aureus bacteremia, I prefer to use cefazolin, but if I deliberately take out the pen and write cloxacillin, there's something about that patient that makes them different. And that difference that led to the physician behavior is often correlated with the outcome because physicians have a sense of who's sick and who isn't sick. Observational data is also substantially confounded by the concept of immortal time. Randomized care, on the other hand, and I'm sorry, my slide is cut off. I have to figure out, there we go. Randomized care, on the other hand, allows for systematic comparisons and meaningful inferences. This is truly the basis of the learning health system, where you let randomization help your system learn in areas of controversy or equipoise. And participation in randomized controlled trials is often of net benefit to the patient's care, both by virtue of standardization, but also by virtue of the kind of closeness of follow-up that they receive. The caveats, of course, is that the primary outcome needs to be generalizable, and there can be substantial sample size and power-related challenges. So you often need a very large sample size to demonstrate differences between similar approaches when you're looking for outcomes such as mortality. And certainly you need not look further than cardiovascular studies looking to prevent myocardial infarction, where there's tens of thousands of participants. And the generalizability aspect of randomized care is important too, because if you really sub-select out a population to study, then it can become more challenging to apply that learning from the randomization process to the general patient population. I think it's important to note that COVID-19 has been an incredible opportunity to learn about how random care has let us down. And it's full of examples where we've either harmed patients, potentially missed benefit, or wasted resources. So if you look for harm, you need not look further than hydroxychloroquine, which was used in a lot of inpatients worldwide in North America and Canada, where a meta-analysis of the inpatient randomized controlled trials, mainly Solidarity and Recovery, show that mortality was increased in patients who received hydroxychloroquine. After the first wave in New York, the concept of full dose anticoagulation in critically ill patients gained a lot of widespread acceptance. The first retrospective cohort study, I think, involved 7,000 patients. Well, unfortunately, randomized controlled trials showed that this strategy was harmful. There was the potential missed benefit, where initial guidance in the disease was to avoid corticosteroids based on observational data from influenza, whereas the randomized controlled trial, mainly Recovery, showed benefit. And then waste. So, you know, the story of convalescent plasma in the United States is fascinating. It became an industry overnight. 700,000 doses of convalescent plasma or more were given, and then it was abandoned for essentially clinical futility and isn't provided anymore in that country. So despite the fact that we've told you that Staph aureus bacteremia is common, that it has a 15 to 25% mortality, it's actually a disease in which there have been a staggeringly few number of randomized controlled trials. If you look at all of the randomized controlled trials before 2020, including all of those in the literature. There's about 2,300 patients total that have been randomized for a disease that kills more than that annually in this country alone. And I highlight the 3 in bold because these were performed by Josh Davis and Steve Tong's group, and by Matthew Cheng here with the infectious diseases fellows. But fortunately, and the purpose of these rounds is to usher in the excitement that we are living in the era of randomized care for Staph aureus bacteremia. And I hope that the remainder of this talk will show you how the SNAP trial is going to revolutionize how we manage this disease. It's going to revolutionize it for all forms of Staph aureus bacteremia, whether that's MRSA and MSSA, and answer numerous questions. And that gets into this concept of the platform trial. Now, this is Dr. Tong's slide, so I guess that is Australian football. Am I guessing right? Yeah, I guess that's an Australian.
No, it's actually rugby union. Todd, this slide came from when I gave a talk in New Zealand.
Okay, so
that's their favorite sport.
So there you go. So this is a sport that I have never played, surprise, with my 140-pound frame in high school. But the concept of the platform trial is to utilize a playing field on which we compare teams being strategies for management. And these comparisons are taking place within a tournament. And the concept of the platform, or the adaptive nature of the platform, allows us to serially determine winners within this tournament to move on to subsequent rounds. And these comparisons can be binary, or they can be more than binary with multiple comparisons. In SNAP trial, it's mostly binary and some interaction-based comparisons, but you can have multiple comparators. And you can have multiple sub-tournaments within the same platform. So, for instance, you could have, in a tennis tournament, you might have the men's division and the women's division and doubles. Well, in Staph aureus, we have penicillin-susceptible Staph aureus, methicillin-susceptible Staph aureus, and methicillin-resistant Staph aureus, each of which can have their own tournament. And the concept of adaptive trials, there's a nice review by the former director of the FDA, Janet Woodcock, in the New England Journal. But the concept of the adaptive platform is to allow these tournaments to be conducted with pre-specified rules about how you move from one round to the other, and how you decide on whether a contest is decided and you need to move on to other strategies. So in an iterative fashion, data collection commences for all of the competitions simultaneously, and at pre-specified periods of time, the available data is analyzed, and these pre-specified stopping rules are applied. If the pre-specified stopping rules are met, and that in the case of SNAP is going to be explained a little bit later, you would stop that phase of the trial and begin a subsequent phase in a seamless design, moving on with your winner. And if the stopping rules are not met, you would continue as per the adaptive algorithm until either futility is met or additional data comes into play from outside of the trial that tells you need to move to a different strategy. Or was this, I thought this was your slide, Steve. But so the concept of SNAP is an international trial, which was designed by principal investigators Steve Tong and Josh Davis in Australia, along with a team there, that has now metastasized to Canada, New Zealand, Singapore, and the United Kingdom. And in Canada, the principal investigators are Matthew Cheng from the McGill University Health Center, who's the nominated principal applicant, myself, Nick Danneman, and Jenny Johnstone from the University of Toronto. And for Canada, we have 19 centers in 13 cities in 6 provinces who are going to participate in SNAP and help us answer these multiple simultaneous questions using an advanced Bayesian platform framework with incredibly pragmatic inclusion and exclusion criteria, some of which are specific to this comparisons that we're making, but that will allow for maximum generalizability.
I'm happy to take over, Todd. If
Yes, this is you now.
Okay, great. Tell me when you come back in. So we really think this is, as Todd mentioned, a revolution in how we will both manage this disease, but also hopefully be a model for other infectious diseases. So we've seen this occur with the recovery trial with COVID, and we're hoping, Todd terms is the recovery of staph bloodstream infections. And so we are aiming for a large sample size of approximately 7,000 participants. And the idea of these platforms is that you actually keep going as long as there's funding and as long as a public health question remains. So whilst we nominally say 7,000 participants, we hope that, by the end of our funding cycle, we'll be able to get funding for the next cycle and in perpetuity continue the trial. With the international involvement at this stage, we're hoping that there will be over 80 sites across these 5, maybe six countries now. And ideally, once we have the infrastructure set up, other sites around the world can join. And we're hoping that once we get runs on the board, other sites elsewhere will find this of interest and will engage with us. And we'll have the databases and the questions and so on already set up. And the incremental cost will really just be to fund each specific site in the different regions. We're aiming to enroll from Q4 of this year, and our database is hopefully nearly ready for opening for enrollment in about a month's time. And we have funding from a number of these local national funding bodies, which means that we're hoping to really open across the world in this year at numerous sites. Thanks, Todd. This is the overview of our trial structure and the kinds of interventions we're looking at. So we're calling them domains, treatment domains in the columns there, and across the rows are our silos representing the different susceptibility patterns. So penicillin susceptible, methicillin susceptible, and methicillin resistant as the 3 mutually exclusive groups. And you can see there's different questions being asked in the backbone antibiotic domain. We're really asking what's the best main backbone antibiotic to treat this specific silo. And we'll go into further details in the rest of the talk there. There's an adjunctive treatment domain, which at the moment is clindamycin versus no clindamycin. But again, down the track, once we answer that question, we can introduce other adjunctive treatments. And there's also a domain looking at what's the best route at those various time points. And again, we'll go into further details. And you can conceptualize this really as being a pragmatic, very inclusive trial. So there will be a broad population of patients with staph bacteremia hospitalized at our participating centers. We're hoping that as many of those as possible will enter into a registry component, which is for patients who either do not qualify because of eligibility or do not consent to be within what we're calling the randomized trial platform. And it's within the randomized trial platform that each of these questions will be addressed. But with the kind of overarching registry, we'll be able to demonstrate how generalizable the results are to the broader population. And then as you can see here, these are what we call our core inclusion and exclusion criteria for entering into the platform. And they are very broadly inclusive. So you only need to satisfy having staph in your bloodstream and being admitted to one of the participating hospitals to satisfy inclusion criteria. And the exclusion criteria, I think that the main one here will be that 72 hours cut off from collection of the index blood culture. So it is quite a tight time frame, particularly given that after the collection of the blood culture, it does take 24 hours at least on average for the blood culture to flag, and then subsequently probably another often 24 hours before you know the susceptibility of the isolate. And then we have various things that mean, you know, if the patient's about to die or it's deemed not in the best interest of that patient, that they won't be enrolled as well. Just the last point there, we are going to include children as well. So the structure of the trial means that there's both a pediatric and adult component. And really, we're really excited about this because our pediatric colleagues so often rely on adult data and extrapolate that to children, but that's not a particularly evidence-based way to practice. And what we're hoping here is that there'll be a large number of children recruited as well, and direct comparisons be able to be made for each of the treatment arms in our statistical model. And the main outcome is 90-day mortality. So we're really most interested in that key incontrovertible outcome. Does this patient die or not? Can we improve mortality rates? And so everything is driven by this 90-day mortality, and all those pre-specified stopping points that Todd mentioned in that adaptive trial process are based on 90-day mortality. And as we've demonstrated so far, that sits around 15 to 20% on average. And then there are a number of key secondary endpoints as well, including all-cause mortality at various time points, how long the patient stays in, and therefore the health economics associated with that, and various specific indicators of either treatment failure or success. Still me, Todd? I'll keep going.
Yeah, go ahead. Going, Steve.
Yeah. And so this is the kind of participant flow that we will see, those broad inclusion criteria, and then the exclusion criteria. If none of those exclusion criteria are met, we will seek consent from the patients for entry into the platform. And once they've given that consent, they enter into the platform. And the way we've organized the randomization is that the patients will be randomized in all those domains and silos at that time point. But then the actual assignment that patient has within that is only revealed down the track once their eligibility for each of those different domains is determined. For patients who do not consent or who are not eligible for the trial, we will then seek consent, at least in Australia, for entry into the registry. There will be some jurisdictions where it's possible that consent may not be required for that. And then I'll hand over to you about the clindamycin, Todd, I think.
Yes, thank you. So one of the first questions that we want to answer across all subdomains of Staph aureus, be it methicillin sensitive or methicillin resistant, is whether there's a role for early adjunctive clindamycin. Now, Staph aureus itself makes a variety of toxins, the production of which can be inhibited by clindamycin, toxins and virulence factors, and clindamycin use in severe disease states like toxic shock syndrome or like severe pyomyositis or necrotizing fasciitis is supported in observational studies with mortality reductions. And the question is whether that will hold mustard in a randomized controlled trial. Certainly, theoretically, 60 years ago, it was demonstrated that beta-lactam monotherapy may not be as effective when you have large quantities of bacteria, and not all of them might be rapidly dividing. So beta-lactams kill organisms like Staph aureus when they're replicating and building new cell wall, because that's where beta-lactams work. But when the organism is not replicating and is more dormant, beta-lactams have less activity, whereas clindamycin retains activity against those in the stationary phase. Clindamycin is, worldwide available and cheap, and so that makes it an ideal candidate for potentially reducing mortality in this disease state. Now, you can't give a talk about clindamycin in the province of Quebec and not talk about Clostridium difficile. And so the very important counterbalancing safety outcome in this area and in the patients that are exposed to clindamycin will be C. difficile. It will be one that the Data Safety Monitoring Board and the Trial Steering Committee follow very closely. But it will be important to analyze it in the concept of competing risk of death, because it's possible that clindamycin will augment survival, and you therefore have more chance of getting C. difficile because you're alive. And so some of the analysis of this outcome will have to take into context the rates of survival between the two groups. In human terms, in Staph aureus bacteremia, there is an interesting prospective study in endocarditis, which has been done out of France, which suggested that a strategy involving early clindamycin is associated with reduced mortality. So we feel pretty confident that this domain will give us something actionable and will be safe to pursue. Once the silo is known, okay, so this is moving down this flow chart. So everyone gets as soon as we know it's Staph aureus, they get randomized and allocated to clindamycin or no clindamycin if they are eligible. And I should mention we are excluding people who've had recent C. difficile from that question. But once that is done and we know the susceptibility pattern based on whether it's penicillin sensitive Staph aureus, penicillin resistant Staph aureus, which we call here MSSA, or MRSA, we have a series of other additional questions. For the penicillin sensitive Staph aureus and the methicillin sensitive Staph aureus silos, basically what we're looking to show is that the organism is methicillin susceptible but penicillin resistant or fully penicillin susceptible. And there are some platform specific exclusions, like if you've had a severe reaction to beta-lactams, obviously we can't randomize you to one or another beta-lactam. We have excluded dialysis patients or patients who are pre-dialysis because we want to avoid unnecessary PICC lines, and cefazolin has an incredible pharmacologic advantage in people on dialysis in that you can avoid a PICC line and just give it on dialysis days. And we exclude people where we just can't answer the question of which bin these patients fit in. Penicillin, I remember when I was a resident, I remember Andy Seymour in Toronto, for those of you who know Dr. Seymour, said to me, we don't bother testing penicillin because it's always resistant. And that was what I learned kind of growing up. And then Matt Cheng, when he was a fellow, and I kind of noticed that we had a couple of penicillin susceptible cases in a short period of time, and we decided to look at how common this was. And if you look at all Staph aureus bacteremia since we moved to the Glen site, and actually we have more penicillin susceptible Staph aureus bacteremia here than we do methicillin resistant Staph aureus. So we really think that answering questions within this group will be particularly valid and arguably as important as answering questions in MRSA, at least in a lot of the Canadian centers. So when you're making a comparison in penicillin susceptible Staph aureus or penicillin resistant methicillin susceptible Staph aureus, the key is that we're going to be comparing against what is the Infectious Diseases Society of America's guideline standard. And the guideline standard essentially is CLOXACILLIN in Canada, NAFCILLIN in the United States, and flucloxacillin in Australia. And the two comparator agents, which we are comparing in a staged non-inferiority superiority design, are penicillin and cefazolin. And the major advantages to cefazolin and penicillin are that they're much less likely to give you allergic interstitial nephritis. That's an awkward page. They're much less likely to give you interstitial nephritis. They're less likely to give you thrombophlebitis at the point of infusion, and they're less likely to give you severe dermatologic side effects. For both penicillin and cefazolin, observational studies have suggested mortality benefit. With the caveats that I told you, which is when I prescribe cloxacillin as opposed to cefazolin or penicillin, there's something about that patient that might be associated with mortality. It may have nothing to do with the treatment, but there is a potential mortality benefit here. And then the disadvantages of penicillin is that there's a theoretical concern that the lab will miscategorize patients, and we're using a two-staged model of testing, which uses complementary tests to minimize that chance. And even if we did miss using those two tests, the relevance is unclear clinically. And the disadvantage for cefazolin is this theoretical concern of inoculum effect and a historic belief that the central nervous system penetration is less, although there have been a number of papers that suggest that is not the case. When I said staged non-inferiority and superiority design, basically what happens is we will run these domains until A, futility, or B, the probability of non-inferiority, defined as an odds ratio of less than or equal to 1.2 for mortality, is greater than 99%. When non-inferiority is declared, there are pre-specified rules to look and see, you know, if we ran this trial for another 500 patients, what is the likelihood that we would find superiority? Because superiority is just a subset of non-inferiority where the confidence interval extends up to an odds ratio of less than 1, as opposed to up to an odds ratio of less than 1.2. And so if there is a mortality benefit to using these agents, number one, the non-inferiority component of the trial will close much faster using the Bayesian design. And number two, we'll continue to look for it because that will be really game-changing in addition to these pharmacologic advantages. Steve, this is you.
Sure. So for MRSA, which is typically more difficult to treat because we don't have the option of using beta-lactams, there therefore has remained questions about the optimal treatment. And vancomycin, we know, isn't a terribly good drug. It doesn't kill the bacteria that quickly, and there can be issues with penetration of the drug to where the disease is. And so many people have theoretically postulated that combination therapy is the way to go. And there's been numerous studies looking at that. One of the ones which combinations which we're most interested in is the use of a beta-lactam in addition to either vancomycin or daptomycin. So here's a figure of why in the test tube we have vancomycin on the x-axis here and bacterial growth on the y-axis. And you can see that with vancomycin alone, this was quite a resistant isolate. It really, you need quite high concentrations of vancomycin to lead to killing of the bacteria. But when the bacteria is cultured together with vancomycin and oxacillin, the equivalent of CLOX or NAFCILLIN, you can see that shifts that curve well to the left. And this phenomenon has been consistently shown in numerous studies, also in animal models. It seems to provide benefit. And so we wanted to try this in humans. It hadn't really been done. And the CAMERA 2 trial was one where we compared the standard of care being vancomycin versus combination therapy with vancomycin plus beta-lactam. In most cases, that was flucloxacillin, but in some cases, it was cefazolin. We looked at a number of different outcomes. We published this in JAMA about a year and a half ago now with about 350 patients. There was no statistically significant difference in the primary outcome, which was a composite of a number of our outcomes. But the really striking thing was that the combination therapy definitely reduced the duration of bacteremia. So for all the patients, we had day 5 blood cultures taken, and you can see with standard of care with vancomycin, about 20% were still bacteremic at that time point compared to 11% in the combination therapy group. However, when you look at the day 90 mortality, it was in fact numerically the other way around. So whilst we had a kind of microbiological effect, this did not translate to an improvement in mortality. And in fact, if you go to the next slide, Todd, what we did at that far right column there is acute kidney injury, is that the addition of flucloxacillin substantially increased the rate of acute kidney injury for these patients, up to 24% compared to 6% with vancomycin monotherapy. We didn't quite see that with cefazolin, so it was clearly the case with flucloxacillin, but for the about 40 patients also who received cefazolin, we didn't see that acute kidney injury as an issue. And so what we're hoping now with what would have been camera 3, but it really has now become a SNAP domain, is to determine whether we can retain that benefit of combination therapy with a beta-lactam, but not have that toxicity of the acute kidney injury. So we're going to compare vancomycin or daptomycin as usual care versus that usual care plus cefazolin. The next question we'll then address is whether the route of therapy basically as patients move through, we've recruited them, they've entered, they've gone into those first 2 domains, and then at day 7, we're going to judge them for how stable they are. And if various criteria are met and they're judged to be eligible, we will reveal the allocation within this domain to either continued intravenous therapy or switch into oral therapy at that stage. For those patients who are not stable at day 7, they'll be assessed again at day 14 for stability, slightly different criteria. But again, if they're stable at that point, their randomization will be revealed and the patient will be allocated to, again, continued intravenous therapy for the rest of their therapy or switch into oral therapy at that stage. And really, why this domain? And we're quite excited about this domain because this is, again, somewhat paradigm shifting. The reality is that the bacteria don't really know or care how the agent gets into the body as long as you get the antibiotic to the site of the infection. And there are now a number of studies in the last 3 or 4 years where oral antibiotics and switching to them have been demonstrated to be non-inferior and perhaps even bordering on superior to intravenous therapy. And these are conditions where our dogma has been you need to treat the whole duration with intravenous therapy. And that's most notably in bacterial endocarditis in the POET trial, where instead of continuing for 4 to 6 weeks, the patients were randomized, I think, at a median of about 17 days or so of intravenous therapy to oral therapy and demonstrated to be safe and equally effective. And of course, oral step down is associated with reduced costs. You can get patients out of the hospital more quickly, out of kind of the OPAT, the outpatient antimicrobial therapy system earlier as well. And importantly for patients, get rid of that central line with its associated complications. So the exclusion criteria are mainly those to do with patients being unable to tolerate or adhere to these oral agents, or if there's no suitable oral agents for them to be used. And so we're hoping that a reasonable number of patients will get and meet eligibility for this criteria. And who's this appropriate for? So in Staphylococcus aureus bacteremia, we separated out into uncomplicated disease and complicated disease by a number of metrics. And for those with uncomplicated disease, which typically will be peripheral intravenous site related infections or skin and soft tissue infections where the abscess has been drained, we feel that there's good equipoise at day 7 to be able to switch. Most of those patients will require a total of 2 weeks of therapy. So that second week of therapy will be where that route of therapy is randomized. For patients with more complicated disease, so they may have deep-seated infections such as endocarditis or bone and joint infections or prosthesis involved. But if they still meet clinical stability at day 14, we again feel that there's equipoise for switching at that time point. And this day 14 group hasn't really been addressed at all so far in staph bacteremia. And it really is on the cusp of being somewhat novel in what we're addressing there. And the oral agent of choice is actually going to be clinician determined, but we provide a peer-reviewed, preference of choices and provide that guidance to sites. And typically this will be a beta-lactam for penicillin susceptible or methicillin susceptible Staph aureus and linezolid for MRSA. It'll be actually quite interesting once we start running the trial to see what clinicians or the study staff choose in terms of their oral agents at the sites and whether they actually stick with what we've provided guidance for. It's important to say we're not, the design is really a strategy trial of the algorithm of oral or intravenous. It's not specifically looking at which oral agent is best. And maybe, you know, if we do show that there's non-inferiority of the oral strategy, that the next iteration will be to look at, well, what oral agent is best when you get to that time point. And one of the other things that we're excited about, and Todd, I'll be interested in your comments about this down the track as to whether this is feasible in Canada or not, is a more simplified consent process. So most patients, or most trials, require about a 20-page patient information and consent form to be put on the table in front of the patient. And the reality is that I don't think most patients actually read, you know, every word that's there. And we do that for regulatory and legal purposes rather than being a patient-centric approach. And so we've tried to take a more patient-centric approach, and this has been informed by some qualitative research we've done. We invited a number of focus groups of survivors of staph bacteremia in a number of centres in Australia, and basically put forward to them this more simplified consent process. And they almost universally much preferred this to that 20-page document. And if anything, they said, look, we want less information rather than more information. We trust you as healthcare providers. And this kind of goes to that idea of embedding the care within usual care as much as possible. It shouldn't be harder to provide randomized care than it does to provide random care. And we've taken, therefore, this embedded kind of process where you can see there's a QR code, there's links throughout, and patients can then go to our website, and this is the next page, Todd, for more information. So if a patient reads that, goes through that 4-page document, and they may well say, that's enough information for me to consent. But for some patients, they will want to have more information, and then they can follow those links to the website and ask, satisfy what they need to know to be able to provide informed consent. And our ethics committee has actually just fully approved this approach, and we're quite excited by that, because this again could be a bit of a paradigm shift in how we conduct such trials. So next slide. And with that, we've provided some patient-centered videos as well. So each of these runs for 4 or 5 minutes and provides in video and the kind of form with talkovers, the background to the trial and further things that the patients can find out about. And we've actually had these also translated into French, and I haven't actually seen it yet, but apparently there's videos now of me speaking, dubbed over to speak French, which I'm looking forward to actually seeing. So in conclusion, it is, I think, a really exciting time in infectious diseases with the launch of SNAP, and we're hoping that this will not just be for this kind of approach for Staph aureus bloodstream infections, and I know that Todd and I and others have been talking about other infectious diseases as well, but we'll be able to, in parallel, evaluate the choice of agents, where the combination therapy works better, and trying to optimize the dose of the route, of that treatment as well. We are going to continue to need to innovate in both statistical methodology and trial design. And ideally, we'll be able to bring in new treatments as well in a seamless way. So it might be that there's different treatments that come on board. We can introduce that for, say, 200 patients and have statistical criteria to say, well, if we meet such criteria, we will then continue with this into a truly phase 3 design and bring it into the entire platform for testing. And the kind of broad inclusion criteria mean that we hope generalizability to the broader Staph aureus population will be present. And I think having multiple sites across multiple countries, and hopefully that will continue to grow, will mean that we can generalize this to each of the different regions involved. So perhaps I'll stop there and we can take questions.
Thank you very much to both of you. Outstanding presentation, and congratulations on this international initiative to answer a very, very important question. Congratulations on leading this and taking this on. And we will help you at the MUHC in any way that we can, I am sure. We have quite a few questions already in the chat. Dr. Pilote, Louise Pilote wants to know that with the adaptive design and domain setup, is there not a built-in selection bias going on, and how's that going to affect the responders?
I can try and take that. I'm not sure I entirely follow what you mean by the selection bias. There are kind of pre-specified, fairly strict criteria for who is eligible and who is not. There may be introduced bias in terms of one of the eligibility criteria is that the treating clinical team deems it's not in the best interest of this patient to be in the trial. I'm not sure if I've quite gotten to the nub of your question there.
If I may, Steve, I might add on that, that obviously we've glossed over a lot of kind of the advanced statistics of the kind of Bayesian hierarchical setup of the trial, but working with Berry Consultants, who is probably the biggest Bayesian clinical trial development statistical firm, we've looked at how and modeled and designed the analysis to look at how these different domains and different silos kind of interact with each other, and how we will be borrowing information from one aspect of the trial in order to inform the other. Because for sure, the non-inferiority question of penicillin versus cloxacillin might be informed by that patient's status in the clindamycin adjunctive domain. And so the interactions and the interplay between these are all computationally complex and has been simulated and designed before we even put the first patient in the trial.
Thank you. And the next question coming to you is from Mark Roger, talking about platform trials in general. Can you speak about implementation advantages and disadvantages of platform RCTs versus traditional multiple individual RCTs? Example, things like regulatory approval or ethics approval efficiency, sharing of academic credit issues. Can we do this in other disease areas?
So I'll have a first stab at this one as well. So look, they are clearly more complicated, and I think not just incrementally so, that there's, once you start adding in all these domains and silos and so on, it's greater than the sum of its parts in terms of complexity. So it has taken us a long time to get this set up, and I think that needs to be taken into account. And I think the use of these Bayesian adaptive approaches is still, clinicians are still getting their minds around it. So if you read the REMAP CAP studies for COVID and their use of Bayesian analyses, they don't necessarily come intuitively, and the field is I think moving. The fact that those publications have been in major journals suggests that at least the journals are starting to accept them, but it is more complex to understand. The advantages are the idea of that platform. So those fields, that Todd showed, means that instead of each time you run a trial, setting up all the infrastructure again and again and again, and then letting that infrastructure go to waste once you finished your trial and waiting for funding for the next round, is that we set up that stadium, and you can keep playing the games on that stadium. And that means that infrastructure has been set up, the upfront costs have been dealt with, and you continue to use that infrastructure. So I think that's one of the key benefits of it. And hopefully it will be more efficient. So we'll see. This is what, we're trying something that's quite new. And I think that your question about whether this could be done in all disease areas, there will be times when it's not appropriate for a kind of platform trial. But I think there are many more times when it will be an appropriate approach, and we should be thinking about using it.
And along the same lines, do you plan to use this trial infrastructure to identify or develop new predictive or prognostic biomarkers, or refine old ones like procalcitonin?
I can answer that again, and Matthew's provided a brief reply to that. So the answer is absolutely yes, and we're hoping that we can do the translational science that underlies the I guess clinical trial questions, the key questions we're trying to answer. But if we can do the translational underlying science to determine the mechanistic reasons for, treatment A being better than treatment B, that will clearly advance things a lot further. And we're hoping to use the infrastructure that we've developed to allow for all these kind of additional sub-studies. And we're really opening that up to people to say, if you've got a great idea and that can make use of this infrastructure and this platform, please approach us and we can think about including it as a sub-study.
Thank you. I think a question for Todd, which is a little bit more local question coming to you from Kevin Schwartzman. He's impressed with your consent form. It does look really interesting, the platform. He's wondering about the approval at the REB, at the MUHC or other Canadian sites. I think a lot of us feel that REB tends to be quite conservative, but you've managed to get this approved, the consent process and everything. Can you tell us about that experience?
Yeah, so we're conditionally approved here. We're just waiting on some contract-related issues, and there's one domain of the trial which is subject to Health Canada oversight, so we're waiting for Health Canada. But the REB was incredibly embracing of the kind of unified modular consent process, where we, essentially consent people to be in the trial kind of as a whole. And then we explain to them the kind of things that might happen as being part of that trial, but without necessarily drilling down and saying, do you consent to be in this section of the trial? Do you consent to be in that section of the trial? So they've actually been quite, quite accommodating and engaged in the process of doing things this way, which of course means from a Nagano point of view, the province of Quebec becomes much easier to do this way. And we're going to leverage that in the province of Ontario through their centralized process to, again, go with a single unified consent. So we weren't able to use the form that Steve and the Australian team put together. We had to use our form, but that form looks much more like Steve's than it does like a 20-page tome.
Fantastic. Congratulations. I think it's going to help advance how many of us do research at the MUHC. So you're setting a new standard for us. There's one last question here that I see about specifically about the trial. Did the patients need to be hospitalized during the whole duration of participation, or can they be discharged with IV antibiotics, for instance, before day 7?
I can speak to that here. Essentially, the patients could go before day 7. The reality is most of the time with Staph aureus bacteremia, it takes somewhere around 5 to 7 days to get all the investigations done and make sure that the patient is doing well and kind of set up the outpatient management. But there's no requirement that the patient has to be in the hospital before day 7, and we'll transition them to outpatient antibiotics before day 7 if that's appropriate, and then we could assess them for oral step down in the day hospital or in the clinic. So there won't be an increased length of stay as a function of being on this clinical trial.
Thank you so much. There's a few comments there that I'll let you read in the chat, all very positive and congratulating you on this initiative. They want one last thing here. How did you manage to get the funding? You have 2 minutes left to answer that, Todd. How did you get funding for this?
Well, we had a wonderful template from our Australian colleagues describing the platform as a whole, and then Matthew Chang did an incredible job in writing an elegant grant. He and I did with the help of Nick and Jenny and the rest of the Canadian investigators. And we went to randomized control trial committee, and it took us 3 tries. But on the third try, we found the right sauce. And the randomized controlled trial committee, it's a hard nut to crack, and it depends who else is there. So if those of you who are applying to RCT committee, you just need to just keep applying every cycle. And we had the good fortune of being highly rated this time.
Fantastic. Congratulations, Dr. Lee, Dr. Tong. Thank you so much for joining us and sharing this terrific initiative with us. We wish you good luck. And please do come back in a year and let us know how things are going. Thanks, everyone, for joining us, and we'll see you next week.